But the real technique of performing a third space endoscopy procedure began in 2007 because of the animal experiments conducted by Chris Gostow from the Mayo Clinic and Pankaj Pasricha from Galveston, Texas, and also from the Johns Hopkins. And they showed for the first time that you can make an incision in the mucosa of the esophagus of porcine living models, enter inside the submucosal space, and then create a tunnel in the submucosal space. And then through the tunnel, you can do something in the muscle or even outside the muscle. For example, Chris Gostow demonstrated that you can take a biopsy of the muscle, or you can go outside the muscle and take a biopsy from structures outside the muscle of the esophagus. Whereas Pankaj Pasricha was the first to conceive the idea that you can actually do a myotomy from inside instead of just taking a biopsy and cut the circular muscle fibers and actually do this procedure for the achalasia cardia. As all of you know, that it was Pankaj Pasricha who first described botulinum toxin for achalasia cardia, and he was the same person who came up with this idea that a POEM procedure can be performed, and all the living pigs in which he performed that myotomy, all those pigs survived. And this gave birth to per oral endoscopic myotomy. And the first human study on per oral endoscopic myotomy was published by Haru Inoi from Japan. And he showed in a series of 10 patients that 10 to 15 centimeters above the esophagogastric junction, in patients having achalasia cardia, you can make an entry into the submucosa by injecting some fluid into the submucosa. Because as I told you before, the submucosa contains only areolar tissue and blood vessels which are crossing from the mediastinum and going across the submucosa and supplying blood to the mucosa. So that's the only thing that is containing remain inside the submucosa, that is the third space. But it is a potential space. So by injecting fluid, that third space expands and you can actually push your scope inside the third space. And then starting about 10-15 centimeters above the OG junction, you can make a longitudinal tunneling by submucosal dissection and go right till the OG junction, a few centimeters beyond the OG junction. And once this complete tunnel has been done, then you pull the endoscope back, and a few centimeters distal to your mucosal entry, you start cutting the muscle. So actually what we are doing by cutting the muscle is we are completely opening up the mediastinum. But fortunately, the scope doesn't enter directly in the mediastinum because there is some tissue between the structures outside and inside the esophagus. And that tissue is by areolar tissue. There is a little bit of a fascia there and some amount of fat. So you see here, you can cut the muscle. And after doing this myotomy, all that you do is to achieve a hemostasis, pull back the scope and close this mucosal incision. So then what happens is, even though you have done a complete myotomy, opened up the mediastinum over here, this mucosal flap seals this entire tunnel. And therefore, this procedure becomes extremely safe. So it was Inouye who showed that in patients of achalasia cardia, it was technically feasible to do a myotomy like this completely and then close this mucosal incision. And all these patients scopically or open surgically performed. You before, and I did POEM procedure in India in October 2012. Without any training in endoscopy before. Of course, I used to do routinely ERCP and other dimensional endoscopic procedures. You can see I was very young that time. I had black hair, dark hair. And this was the first patient who was having dysphagia for almost 7 years, could not even swallow water. And 24 hours after the first POEM procedure, I'm giving her a glass of water to drink. And the patient and me both happy to see it. Now, since this invention, more than 12 years back, if you see today, there are
Recording
feed
in
the patient for a
progress.
month or so. And after that, when you go in, you will find that the mucosa, even if it is like this before, it can become healthy only by giving rest to the esophagus, preventing any stasis inside the esophagus. So keep the patient NBM, at the most allow the patient a little bit of clear liquids, but only feed the patient through an NG or an NJ tube. What about the pre-procedure preparation and pre-medication? These are the things which right from the beginning, right from 2012, I've been following, and I'm finding this extremely useful, which nowadays many of the endoscopists to perform the POEM procedure do not follow. They are not still aware of this. But I'll tell you what, keep the patients on clear liquids for 2 days. Do an endoscopic washing 1 day before, very, very essential. And give the patient some PPI and tranquilizer on the previous night because this can cause a little bit of anxiety. And on the day of the procedure, we have made it a habit and a routine to give these patients 100 micrograms of clonidine to make sure that their blood pressure is always under control during the procedure. Because if the blood pressure is high during the procedure, it can bleed. Even the smallest of blood vessel which you encounter during tunneling will keep on bleeding, oozing, and your whole procedure will get delayed. And you may have to even abandon or sometimes create a complication. Next is to give some pregabalin beforehand, because when you cut the muscle fibers of the esophagus, there are some nerve endings in the muscle fibers. So to reduce the post-procedure pain, you give a pregabalin beforehand. PPI and ondansetron, of course, is also useful. Next step is intra-procedural preparation of the operation theater. So the patient usually is kept in the supine position. Nowadays, all the POEM procedures we do with the patient in a supine position. Endotracheal tube is placed. The assistant's trolley is just at the head. The tubes are facing the endoscopist in front of the endoscopist, opposite side. And you see her, the monitoring equipment here, and this is the diathermy. Diathermy, this is the patient monitor. You can see here, ideal monitoring, ideal parameters here. Pulse rate is only 60. You see here, EtCO2, all these patients have to be monitored by measuring the CO2 level of the blood, because these procedures are performed by stopping the air pump, and we have to give only carbon dioxide insufflation because you are potentially opening the mediastinum. If you insufflate air, you can have a disastrous complication. So to shut off the air pump, only start CO2, but keep on monitoring the CO2, and that too in a controlled fashion. So a very simple trick for India, what we do is, to this CO2 tube, we attach this bivalve. And by attaching this bivalve, we can control the amount and the number of bubbles which are coming out of the scope of the carbon dioxide. And with this, very, very slow insufflation with carbon dioxide is essential. Then what about the injectate? Which fluid do you inject? So we take normal saline, in which we mix some blue color. Ideally, you should use indigo carbene, but we can even use methylene blue. But look at the color. The color has to be sky blue. It should not be dark blue. There is a mistake which some beginners do, where they put too much amount of indigo carbene in all methylene blue. And if this color is too dark, you may not be able to differentiate the tissues inside while tunneling. So this color has to be sky blue. You can see which is there inside the syringes. Then, of course, the diathermy settings, I'll come to that later. And this is the knives we're going to use, which have to be laid down on the trolley. So what are we going to do? What knives are used for the POEM procedure? The common two types of knives which we used in the POEM procedure is this Olympus TTJ knife, which is a triangle tip knife through which there's a small hole, and there's also water jet which can come out. So it's called the TTJ, triangle tip J knife. And you can use the hybrid knife. Either you can use the T-type hybrid knife, or the I-type hybrid knife, or the ball type, O-type hybrid knife. So the hybrid knife has got the advantage that it is attached to a water jet. So therefore, even if you just put the knife there in the tissue and press the pedal of the water jet, the water goes inside in the form of a jet. So therefore, the submucosal tunnel which you're creating, that water fills up the tunnel very fast, and there is a very nice fluid cushion which can form. Same thing can be achieved with a TTJ knife, of course, but you have to inject the water with the hand, or sometimes we can also attach it to a pump. In some situations, we have to use this hook type of knife, and this hook type of knife, which also has got a water jet function, or you may have to use this insulated tip knife, or even the dual knife or the flush knife. Dual knife is from Olympus, whereas the flush knife is from Fujinon company. To initially give the injection, we use a simple 21 gauge or 23 gauge sclerotherapy needle. With this needle, we can puncture the mucosa and give that injection into the third space. To achieve a hemostasis, we use this forceps, which is called as the coag grasper or the coagulation forceps from Olympus. And finally, to close the mucosal incision, we can use a variety of clips. We can use different types of clips. There are nowadays clips available from various different companies. It entirely depends upon your choice. But these are the instruments which you have to keep ready at the time of doing your POEM procedure. Before doing the POEM procedure, you have to attach a cap at the distal end of your endoscope. Why? Because this cap acts as a dissecting mechanism. By attaching the cap, what happens is as you keep on pushing the scope ahead, the cap displaces the tissue away, and that way the tunnel creation is become better. If you directly use the scope, you'll not be able to keep that layers from approximating on each other. The common cap which we nowadays use is the straight cap from Olympus, which is completely here. From CO2 can come out. So this cap is attached to the tip of the scope. Or some endoscopists also prefer to use this tapered cap, which is called as the ST hood from Fujifilm or Fuji. Especially if you find submucosal fibrosis, it's a difficult tunneling, then it's a good idea to use this cap because tunneling becomes a little bit easier with this cap instead of doing a straight cap. The same cap is used for doing submucosal tunneling ESD procedures, which has been championed or propagated predominantly by Yamamoto from Japan. What about the energy devices or diathermy devices? The two main energy devices which we use, one is either the Olympus, which is called as the ESG 400, or we have got the YO3 from Urbe. If you're using the hybrid knife, of course, we use this YO3, but in general, most of the units in this country use the YO department, with the YO cautery, the Urbe cautery. And you can see here that there are various cutting modes and coagulating modes on both these cauteries. For example, in Olympus cautery, when you are using a cutting mode, you use the blended current, and coagulation modes, you can use the soft forced coag or the spray coag. The Urbe cautery, the most common current which we use is the endocut Q, and we keep a setting of 233, that is level 2, cut 3 and cut interval 3, 233, which is the typical classical POEM setting. Whereas for coagulating modes, we use the soft coag or the first coag. It is important to remember that even though it is called soft coag, this coagulation goes deeper because it is a slow coagulation. It is cooking the tissue. So if you have a vessel which is very thick coming from the muscle and you want to coagulate it very, very effectively and reliably, then we use the soft coag. Whereas you want to just blast that vessel, it's a small vessel, you can use the forced coag, and forced coag current can also be used for cutting. So in certain situations, only by keeping your mode on forced coag, you can do your entire dissection with a forced coag. And very recently introduced in the YO3 is called the precise current, which is also cutting also. So this is how we do by using the precise sect. The advantage of precise sect is that if you move the knife fast, it cuts. But if you keep the knife at one location for a little longer, it coagulates. And it cuts almost like doing cutting with a scalpel blade. So the precise sect is one of the modalities which I personally prefer nowadays for the POEM procedure. Now coming to the exact technique of performing the POEM procedure. The first step is cleaning of the esophagus and assessment of the resistance at the junction. You see here it's containing a lot of food debris. So you clean it with a proper water jet. Your endoscope should be having a special channel for water jet. And with this, we are cleaning the esophagus, cleaning the stomach. And once we have cleaned the esophagus and the stomach, the next step is to inside the submucosa or the third space. So there are two methods of doing this. Number one is you poke the needle, and as you inject, you pull the needle back. As soon as the needle comes in the submucosa, you'll start getting this bleb. Or the second way of doing it is you start injection outside in the lumen, and as the injection is being given, you insert the needle inside. And as you're inserting, you will suddenly get a bleb. So this way, you achieve that bleb. Now this bleb which occurs indicates that your fluid has entered the third space of the submucosa. Now once this is done, you keep on injecting as much fluid as possible, 20 cc, 30 cc, so that later on you don't have to do too much work of injecting the fluid. Now, once this fluid has been injected, you pull the scope back 10 to centimeters above the esophagogastric junction, and depending upon the subtype of achalasia, you have to select the length, how much long tunnel you want to do. For example, if you have a type 1 achalasia where the esophageal body peristalsis is not good, you should not do a very long tunneling or a very long myotomy. You do a short length myotomy, therefore you need a short length tunnel. You don't have to come all the way 15 centimeters above the OG junction. It can be only 7-8 centimeters above. Enter the tunnel and perform a myotomy predominantly at the lower esophageal sphincter. But if you have a type 2, it should be a moderate length tunnel, maybe around 8 to 10 centimeters. But if you have a type 3 achalasia, then you have to do a long tunnel because you need to do a long myotomy. So the next step is now to perform the mucosal incision. Here you can see that I'm using the hybrid knife from Urbe. So I made the first cut, which is usually a coag current. And then by hooking that knife inside, I'm pulling my scope backward and slowly making this longitudinal cut inside the mucosa. Now, how long to cut? So the length of your cut should be just longer or larger than the diameter of the cap which you have attached to the tip of the scope. And if your length is not longer or larger than the diameter of your cap, then what can happen is you'll not be able to enter the tunnel. Now look at this step, what I'm showing you. After cutting the mucosa, the next step is to cut the muscularis mucosa or the lamina propria. And many times a beginner does not do this and therefore struggles to enter inside the third space. So I'm hooking the knife on the left edge, on the right edge, and also at the apex. And you see here how I'm dissecting those areolar fibers in the submucosal space carefully before rotating my scope and entering inside the third space. So don't be in a hurry to push the scope in the third space. First, make your mucosal incision properly, and then very, very easily you will be able to enter inside the third space. Now, if you were to see here, after entering in the third space, what do you see? So what you see here now is this whitish area. This is the muscle, whereas this is the areolar tissue in the mucosa. Already you can start seeing one small blood vessel which is coming from the mediastinum, crossing the submucosa and supplying blood to the mucosa. This side is going to be the mucosa, this is the muscle, and this is your third space. So now you have made an entry, you have started seeing the muscle fibers here. So now the next step is going to be start doing the tunneling. Now look at this, how I'm going to do the tunneling. Keep the knife projecting out of the scope. Don't touch the knife now. Let the knife remain at one place. Only hold the shaft of your scope and with your left thumb, keep on turning and changing or rotating the big wheel and the small wheel. And by rotating the endoscope clockwise and anti-clockwise, you keep on using the endocut Q current and keep on dissecting the areolar fibers of the third space. If you see a vessel like this, go by the side of the vessel, keep the knife there and press forced coag current. You see how the tiny vessel has got coagulated? And if the vessel diameter size is lesser than the size of your knife, then you quite easily and safely cut it by only with the knife. But if the vessel is thick, then you have to take out this knife, put in a coag grasper, and coagulate the vessel right at the muscle area where it is emerging from the muscle. So now, as you keep on dissecting this, stay as close to the muscle as possible so that we bear the circular muscle fibers. Can you see the circular muscle fibers down here? So why do you do this? Because you don't want to lose the path. Now, even if there are some turns and the esophagus is a little bit curved because of long-standing achalasia, all that you have to do is your tunnel has to go perpendicular to the circular muscle fibers. And if you keep on going at right angle to the circular muscle fibers, you'll always reach the OG junction. You'll not get lost in the submucosal tunnel. These small vessels which you see on the muscle, coagulate them as you keep on going ahead. Now, very, very important to tell you is, as you keep on going ahead, you keep on visualizing the areolar fibers. For example, this vessel is seen behind there. Even by mistake, don't cut it. So inject fluid by the side of the vessel, on the left side, on the right side, and you can see how the vessel is emerging from the muscle, coming from the mediastinum. Now, this is a thick vessel. So for this vessel, you have to use the coag grasper. So now see how I'm using the coag grasper. We open the coag grasper, put it right at the place where the vessel is emerging on the muscle. You're not going to do any harm because anyway you're going to cut the muscle later on. And then apply soft coag or post coag, depending upon whether this vessel is becoming completely coagulated. So you have to cook the vessel, cook the area from where it is coming out, so that when you ultimately cut the vessel, it is not going to bleed. So with the same instrument, after you have achieved coagulation, you can press the yellow pedal and you can achieve cutting of the vessel. Now, you see what I'm doing now? Now, first we have achieved coagulation. And after doing coagulation, now I'm going to cut the vessel. So again, I'm going to do little coagulation. We can see a little bit of red tissue inside the vessel here. And then we cut the vessel. And once the vessel is cut, you can proceed and go ahead with your submucosal tunneling. You see here now that this way we are cutting the vessel and then the dissection proceeds. And you keep on tunneling ahead. Now, it's important to know how long to do the tunnel. So optimizing the width and the length of the submucosal tunnel. Because as you keep on dissecting, the muscle fibers, you can keep on seeing here, you're exposing the circular muscle fibers. And as you come to the lower esophageal sphincter, you see here that the space becomes narrower. But you can inject the fluid under pressure so that you can see the submucosal tissue. Just keep on dissecting, and by rotating the scope, just enter inside as much as possible. Now, as you go to the OG junction, there are a few landmarks which you are going to see here. Number one, this narrow area in the tunnel suddenly becomes wide. When you cross the OG, these palisade vessels which are there on the muscle. This is the second identification that you are nearing the OG junction. And the third is you see two perforators, usually in most of the patients, which are coming from the mediastinum, crossing the submucosa and giving blood supply to the mucosa. This is called the TPV sign or the two perforator sign. Why is it important? Because the two perforator sign usually tells you that you have come to the OG junction, and when you're going to do the myotomy, your myotomy has to be on the right side of the two perforators. Why? That way you can preserve the sling fibers of the stomach. Now, all this why we are going to do is, after the tunneling is completed, you should be able to identify the sling fibers and the clasp fibers which are over here. You see now that slowly this tunnel is becoming more roomier. That means now we have started entering the stomach. So we keep on going ahead, keep on dissecting further. And as we keep on dissecting further, you can see here, this is the two perforator vessels. This is the vessels. So in this particular case, of course, I have coagulated and ligated the vessels, and then we keep on dissecting ahead. And at this level now you'll see that these are the sling fibers of the stomach, whereas these are the clasp fibers of the stomach. You should be able to identify this because while doing the myotomy, you should not cut these fibers as far as possible. Because if you can avoid cutting these fibers, this is one way by which you can say you can prevent GERD after the POEM procedure. Because the sling fibers are the ones which prevent the reflux. And another way of knowing that your tunnel is optimized is by using a double endoscope technique. You can pass ultra-thin scope in the stomach, take a U-turn, and look at the transillumination. You can see the transillumination over here. Here, this side are the sling fibers. So therefore, your cutting has to be on this direction. And this is the two perforator vessel side. So once optimize the width and the length of the submucosal tunnel, don't make a narrow tunnel. It's very important that you make a reasonably wide tunnel. After that, the time has come for myotomy. So once you have done an optimal tunneling, how much to go inside? You should go only 2 to 3 centimeters beyond the esophagogastric junction. In the initial stages, most of the endoscopists, in their enthusiasm, tend to go too deep in the stomach, and these patients develop a lot of GERD after the procedure. So go optimal cutting of the gastric fibers. So how do we do the myotomy now? I personally prefer to do a full thickness myotomy. So the first cut is done by using a coagulation current and then hooking the knife below the circular muscle fibers. You see here, I'm cutting the circular muscle fibers. Below, automatically the longitudinal muscle fibers are also getting separated. And outside, what you're going to see is the fat which is on the mediastinum. This is a posterior POEM, which we usually prefer now. Most of the endoscopists in the world are doing a posterior POEM where you don't have any major structures except for the lung. You may see the pleura outside, but you don't have to go near it because you are always cutting towards the lumen. You don't cut this way. Only if the tunnel is very, very narrow, then you have to cut from distal to proximal by using an insulated tip knife, making sure that your cut doesn't go deep and you don't damage the pleura. Because by mistake, if you open the pleura, which is there, which is seen here, then sometimes you may cause consolidation or atelectasis to happen after the procedure. So this way now, in a longitudinal fashion, we keep on cutting the circular muscle fibers, along with them also the longitudinal muscle fibers, perform a full thickness myotomy, keep on going towards the OG junction. And at one point, you'll realize that that whole tightness at the OG junction completely disappears and you come to the end of the tunnel. So this way, you keep on dissecting. And at the end now, once you have come to the end of the tunnel, the last fibers, what you see here, instead of trying to use the knife, you can cut the same fibers by using a quiet grasping forceps. I personally also tend to separate the tissue which is on the prevent the muscle coming towards each other after the POEM procedure. Now, this, of course, technique I've developed over the years. I have found that if you do this, then the results of POEM are very long lasting. The chances that your patient will get recurrence are extremely low. So these are some tissue attachments over here below the muscle, which also you can catch, coagulate, and release this muscle, the edges of the muscle. So once you have performed the complete myotomy, you can do the closure. Nowadays, for a proper objective assessment, whether your tunneling and myotomy is complete, we do this technique of endoflip. Now, endoflip is an impedance planimetry where you can actually measure the distensibility index of the lower esophageal sphincter. You can see here, before the procedure, you have the distensibility index like this. After the procedure, it is like this. And if you have optimal distensibility index, the chances that this patient will develop post-procedure GERD are minimized considerably. So ideally, endoflip should be used in every POEM procedure. Unfortunately, it is not very easily available in our country. Fortunately, we have it in our department. Nowadays, we are using it in every patient where we do the POEM procedure, where intraoperatively, during the POEM procedure, we perform the endoflip and we actually measure the distensibility index. And according to the distensibility, we would never allow it to go beyond 10. It should be somewhere between 4 to 10, because if it goes beyond 10, then this patient is likely to have GERD. I mentioned to you that the POEM procedure can also be followed up by the fundoplication procedure. This was, of course, before we used the endoflip. As an extension of the POEM procedure, we can also go across the muscle, enter the peritoneum, and perform a fundoplication procedure through the endoscope, flexible endoscope itself. The only thing here is that we have to perform an anterior myotomy for this, because in a posterior myotomy, we will not be able to enter the peritoneum. So here you can see here, now we are performing an anterior tunneling. We go in, and then by performing, going beyond the muscle, we are cutting the visceral peritoneum outside. We enter inside the peritoneum. And once we are going in the peritoneum, I'm going to pull the stomach, pull it inside. And you can see here now that this way we can achieve a fundoplication. So we pull the stomach, greater curvature of the stomach inside the tunnel, and fix this stomach to the edges of the myotomy using a loop and a clip technique. You see now, this is what we do. We are attaching the loop and the clip by using these clips. And then after doing this fundoplication, if you perform the endoscopy again, you'll see here the result is almost, it looks as if you have performed a laparoscopic fundoplication. You see here how it is pulled inside. This was very, very interesting, and some centers started performing this. But in our experience, this was not a very secure and long-lasting procedure, because the securing or the pulling the stomach inside, attaching it to the muscle, was being done only by loop and a clip technique, which released or gave way after a few months. So now we are developing this technique further. Inouye, who described this technique, has come out with a suturing technique now, where you actually use a needle. Now, as an extension of submucosal tunneling or third space endoscopy, the next procedure, which many of you who start the POEM procedure will be able to do, is submucosal tunneling endoscopic resection of tumors in the submucosa, of subepithelial tumors. Classic tumor to remove in the beginning stages is a leiomyoma in the esophagus, which is a little bit big, which patient is symptomatic, where you can do a submucosal tunneling, and almost like underwater swimming, you can go dissect out this leiomyoma, take it out from the muscle connection, and take the entire tumor, submucosal tumor, out of the mouth. Just to show you how we do it, this is the leiomyoma which you see here in the mid esophagus. So, little bit proximal to this tumor, we enter into the submucosal tunnel and we keep on dissecting ahead. And as we keep on dissecting ahead, you see here, this tumor is now appearing in the submucosa. Below, it is attached to the muscle. Upper part is in close approximation to the mucosa. So by using variety of knives, this is the classic case where we use the insulated tip knife. Here, of course, I'm using the hybrid knife from Herbe. And once we have dissected this entire leiomyoma from all sides, you dissect it from the muscle layer, from below, catch the leiomyoma with a snare and pull the whole thing out of the tunnel. You see here, then afterwards you go inside, you see the place of the defect, you can achieve a little bit of hemostasis and then close the mucosal incision. So excellent way of treatment of subepithelial tumors is by using an extension of submucosal tunneling, or called as the stir procedure. Of course, classically described by Professor Yamamoto from Japan, submucosal tunneling is also used for ESD. Here you can see an early cancer, squamous cell cancer of the esophagus. Now, if you were to do an ESD in this patient, normal ESD procedure would take around 5 or 6 hours, because you have to keep on taking the flap, and it's very difficult to retract the specimen away. But by using the tunneling technique here, we have made 4 tunnels below this small area, which is a early cancer of the esophagus. And by making 4 tunnels, you can do an excellent dissection. Or here you can see similar technique being used for the stomach, early gastric cancer in the antrum of the stomach on the greater curvature. We have marked it first, and that one area we start entering inside the tunnel and dissect it below. The entire tumor is dissected below by submucosal tunneling technique, and then just join the edges from the side. And if you do this, the whole procedure becomes much faster than a normal ESD. A normal ESD may take 3 or 4 hours or maybe 5 hours. This procedure can be completed easily within a couple of hours, only because of addition of submucosal tunneling. Same thing can be done for the Zenker's diverticulum. You see here, this is Zenker's diverticulum. You have got the septum in the middle. The problem was, when we used to do a direct septotomy, we were always scared to cut the septum completely because it could cause a perforation. So therefore, this Z-poem or Zenker's oral endoscopic myotomy was developed by Pinggong Zhu from China. Now we have entered the tunnel in the pharynx here. Here, of course, this area is very vascular, so you have to be very careful. But once you go towards the septum, you can see the muscle fibers of the septum. So inside the tunnel, we keep on cutting the muscle fibers. Advantages, because it's a submucosal tunnel, you can cut the muscle fibers completely right till the base, right till the base of the esophagus. And once you have cut the muscle fibers completely, then you can just close the mucosal incision. And you can see here the results of this are much better as compared to a normal septectomy directly with an endoscope. And the recurrence rate of dysphagia or symptoms is much lesser. Now, this technique we have modified a bit nowadays, that instead of doing a long tunnel, we directly make a tunnel on the septum itself. This is very easy for beginners to do. So instead of making a tunnel in the pharynx, you cut on the septum itself, and on both sides of the septum, you make a dissection, submucosal tunneling, and from inside you cut the septum, and then you cut the mucosa and close it with clips. Or sometimes you can even leave it open if you have not made a big opening. So finally, as far as third space endoscopy procedures is concerned, the point is, who should learn this? If you ask me personally, after doing this procedure from October 2012 till 2023 now, I think this, if you are a final year DM or a DNB student, I think you should start getting exposed to third space procedures, because these procedures are going to cause a paradigm shift in the treatment of many issues, many problems, which otherwise would have been tackled by surgery. Classic example is achalasia cardia. Second, of course, is advanced fellows who have done DM and DNB, who are advanced endoscopy fellows. They should definitely learn the basic steps of third space endoscopy. Third, surgeons who want to focus on flexible endoscopic surgery. Surgeons who want to focus on flexible endoscopic surgery and 10 to 15 years post DM or DNB having a fair experience of ERCP. So how should you get trained in third space endoscopy? Number one is to attend live workshops and watch experts keenly. attend hands-on training on animal models for tunneling. Very, very important. I never did that because I had a surgical background. But anybody who is a beginner in third space endoscopy, it's better that you take training on animal models, because a normal pig model esophagus tunneling you can easily learn on these models. Where once you get a hang of doing the submucosal tunneling without perforating the mucosa, I think you will be able to do it in a normal human being. Where start with the poem procedure first and then go on to procedures like STIR or Z poem or submucosal tunneling ESD. First 10 procedures which you do ideally should be along with a proctor who's standing by your side and telling you what to do. But there are going to be barriers in your training. Number one, if you're in solo private practice, it's not easy to practice because one single complication can create trouble and it can create disastrous results. If you have modest infrastructure, you need a lot of infrastructure for doing third space endoscopy. And if you have no institutional backing, you should not do third space endoscopy. Or if the approach of the endoscopist is casual, no. This is almost like flying a plane. There is no margin of error. So therefore, your attitude cannot be casual. You have to have a very keen interest and very, very strict approach while doing the procedure. And of course, if the endoscopy skills are mediocre, I don't think you should venture into third space endoscopy. So how much time will it take for you to become an expert? You ask me personally, after 15 procedures, you will be able to do simple poem cases with an average speed of 10 minutes per centimeter. After 45 procedures, you can tackle complications effectively. But after 75 plus procedures, you will be able to do challenging cases and you can be categorized as an expert in performing third space endoscopy or at least the poem procedure. The future is unbelievable. And to tell you the truth, as an extension of third space endoscopy, we can use nowadays this robot, which is a flexible endoscopic robot, which is likely to come into market very soon. We did the first initial experiments on this robot on the first humans in the world. You see here, only by sitting away, you can use two arms. And if you pass this flexible endoscopic robot through the third space, you can enter the fourth space and perform further procedures because a variety of instruments like this are available, almost like the Da Vinci robot, which is available in surgery. And with this, you can see here now, I'll just show you, by using this robot, by lifting from one side, cutting from the other side, or even suturing like this, you can do a variety of procedures. So the possibilities are likely to be limitless in the future. But as a beginning, I think whatever I told you, learn the basic steps and follow everything properly, and then you will be entered into the field of third space endoscopy. So what is my take-home message? Third space endoscopy, you ask me, is the landmark invention of endoscopy of the last decade. And as far as poem is concerned, it has caused a paradigm shift in the management of achalasia cardia. It has opened a gateway for flexible endoscopic surgery. What is important is you need a mentality of a surgeon, you need a proper infrastructure, and you need good manual dexterity. Of course, needless to say, proper training is required to acquire the right skill set. Thanks for your attention.
Thank you, Dr. Amit, for, I think, is an excellent lecture right from the beginning, the pre-procedural preparation, procedure and the post-procedure, and a very good message to the young colleague that at what level of the practice you can start with the seeing the case. After a year or so, you can watch and how can you learn. Under the proctor, you can do cases, and when you will become a good, when you do the simple cases, when you become the expert. I think is an excellent lecture from the masterly, I think one of the best endoscopists in the world.
Thank you.
Very, very good hand. I request the postgraduate student, if they have any question, they can ask directly or put it in the chat box. So till the postgraduate student...
Sir, there are a few questions in the chat box.
So
chat box and question and answer section.
Yeah, question answer. So
yes,
Dr. Amit?
I can see the questions. First question is, I think, should clonidine be given irrespective of the blood pressure?
Yeah.
I think it should be given because what we do is in between, during the procedure, sometimes because the excessive CO2, because of the dissection, the blood pressure of the patient shoots up. But if you are given clonidine before, then the blood pressure always remains under control. So as a routine step, I think it is better to give clonidine. You will never have hypotension just because of clonidine. So that is question is answered. Second, for submucosal dissection, should be torquing the scope or using the controls. Torquing the scope. As far as possible, don't use the controls. And if you use the control should not be with your right hand. It should be with your left thumb. If you keep on doing a lot of third space procedures, you're going to develop some arthritis at the metacarpal. That much I can tell you, because I've developed it. So what you need to do with your left thumb, you have to torque not only the up-down wheel, but even the left-right wheel as you are torquing the scope with your right hand. These are all simultaneous movements which you have to do. Third, use of ARMA after poem for GERD.
Recording
You can
in
safely do
progress.
it. There's no problem to do ARMA after poem for GERD, because even though you have done a submucosal dissection, ARMA doesn't cause so deep a tissue damage. So it will cause sufficient amount of tissue damage, which causes good amount of scarring. Then can ST, ESD be done for colonic lesions? Yes, it can be done predominantly for rectal lesions, at the most for sigmoid lesions. Some endoscopists who are very, very experienced in third space can also do it for lesions which are in the colon. But as routine, I think it should be done basically for lower colonic lesions. Can we use colloids like Hemaxil for a submucosal fusion? Not required. This is not a ESD procedure where you need the fluid to remain over there for a long time. Because as you're constantly on the move, you're not remaining at one place. You're going to go ahead. So keep on injecting. You want a fluid which goes away, which is a little bit less viscous, where you can see the tissues very well. So use only normal saline in which you add a little bit of color. Any more questions are there?
One more question, Dr. Amit, sir. How do you follow up these patients post-procedure? When do you call for the follow-up post-discharge? Do you prefer doing manometry in spite of use of endoflip during the procedure? 3 questions.
So manometry when? Before or after?
Yeah, after.
Yeah. Manometry we normally do as a routine. We don't do as a routine after the procedure. As a follow-up, let me tell you, normally at least we call the patients 1 month later just to meet them. We perform an upper GI endoscopy to make sure the result is good, and we make sure that the patient has not developed any issues inside the mucosa of the esophagus. May or may not do it, not mandatory to do endoscopy after 1 month. But after 1 month, we call the patient usually for a follow-up, and then directly after 3 months once, and then after 1 year. As far as the diet is concerned, the patient is kept on a liquid diet for 5 days to 1 week, soft diet for another 5 days, 1 week or 10 days, and the patients can start eating normal food, usually after 2 weeks.
So, Dr.
What we need...
Yeah, please go
yes,
ahead. So another question is role of antibiotics during or after the procedure?
So, number one, there is no role of putting antibiotic to your irrigation solution or any antibiotic in your injected. Not. We do give one broad spectrum antibiotic 24 hours before and 24 hours later. So 2 or 3 doses of antibiotics are given. After that, we stop the antibiotic. Routinely, the patient need not be on antibiotic on discharge. No antibiotics required. Because these patients very, very rarely develop any infective complications. And if you are very, very meticulous and careful in the technique what I showed you, anticipate and identify the vessels beforehand, make sure that you stay as close to the muscle as possible, you will not create complications like bleeding or perforation of the mucosa. And select patients properly. Don't land yourself in trouble and then cry. If you select, make sure that the mucosa is healthy, then you will not have submucosal fibrosis. But if your mucosa is not healthy, you are hurried, that means you are very greedy, you want to do a POEM procedure, and you enter the submucosa, you land in trouble. So don't do that. Even in your initial stage of practice, select your patients properly. Very important.
Another question from Dr. Harshvardhan. A recent study from the AIG had shown no significant benefit of sparing sling fiber in preventing symptoms of GERD. What is your experience
And a study from AIG only had said that you should preserve sling fibers. Now they have only come up with another study showing that sling fibers are not required. To tell you the truth, the most objective way to prevent GERD is endoflip. Because I have seen myself with one fiber extra cutting, the distensibility index jumps. So during the if you do endoflip, you can perform the POEM procedure most accurately. And that way, whether you avoid sling fibers, don't avoid sling fibers is immaterial. The amount of depth you go in the stomach is important. That is important.
Dr. Amit, another question from Dr. Aditya Verma.
Yeah.
How many procedures need to be performed on animal model before starting on human?
Oh, 15, 20 procedures is sufficient. Because any endoscopist who is reasonably skilled in doing ERCP and basic interventions can easily learn tunneling. Tunneling is very easy to do, let me tell you. Initially, you're very scared. Initially, you feel that, oh my God, I'm dissecting in the mediastinum. What will happen? I'll perforate this, perforate that. But once you get the hang of submucosal tunneling, it's very addicting. And all of us who are doing POEM procedure, Rajesh will agree with me that it is addicting procedure.
Agreed.
And you will be able to do it very easily. 15, 20 animal models, you'll be able to do the procedure.
A learning curve in comparison to ERCP and EUS, I think, is less.
Yes. See, because ERCP, the anatomy is different with every patient. The ampulla of Vater is changing. And the cannulation techniques, it can lead to disastrous complications. If by mistake you do any complication in ERCP, it can lead to even death. Of course, in POEM also it can happen, but the learning process is much faster in POEM than for ERCP.
Another question from Dr. Virendra Chauhan. How to manage hematoma after procedure if it happens?
Very good question. If the patient is not very symptomatic, you can just wait and do nothing. Many times that hematoma will settle down on its own, everything will go away. If the patient is very symptomatic, if blood starts oozing out of the mucosa, if the mucosal incision and your clips, and patient has drop of hemoglobin, patient has pain in the chest, that means there is ongoing spurting bleeding inside. If that is the case, open up your clips, just pull the clips with that tooth forceps, open up the incision, scope, clean out the hematoma, pull the hematoma out of the tunnel, wash it, irrigate it properly, you will find a bleeding vessel. And once you find the bleeding vessel, catch it with a coag grasping forceps, coagulate it, and then close the tunnel again. That should be done.
Okay. So, Dr. Amit, I will just ask a very important thing. You have discussed, guide them if the bleeding happens during the procedure. How to control the bleeding? What are the steps you are going to take? Because you have described nicely. I know the time constraint was there, but if you can tell them if the bleeding happens, how can you stop making the full clear reason?
See, number one is don't keep on sucking the blood. Same as you do in varices. In the bleeding varices, if you go in the stomach or esophagus and start sucking the blood, you are inviting trouble because the blood comes on your scope and the whole vision goes away. So instead of that, keep patience, keep calm, keep cool, keep on insufflating carbon dioxide, CO2, intermittently give a little wash, go towards the area which is actively spurting, and with the pressure of the cap itself, just press on it a little bit and wait. Possibly that bleeding controls a little bit and then you can see the blood vessel better. Again, pull the scope back, again keep on flushing, small squirts of irrigation. At one point in time, you will be able to locate the spurter. As far as possible, don't try to catch the mucosa. So if the spurter is coming from lower part somewhere, you can easily catch the muscle. You can even be a little bold in catching tissues over the mediastinum. Pull the forceps back while applying coagulation current and then coagulate the vessel. That is the technique of stopping the bleeding.
And if the bleeding happens towards the mucosa from the mucosal side?
Well, then your choice, then what you do is inject some fluid in the tissues around the blood vessel so that the mucosa goes away and there is some fluid cushion around the blooding vessel and then you can catch it so that you don't damage the mucosa and create a perforation.
Another important question, if the mucosal injury happen, should we continue with the procedure or first close the incision, injury, and then proceed with the number one? Number second, which grade of the mucosal injury, because sometime you complete the procedure, you signed a small blab. Should you apply the clip or you wait? Can you guide them?
See, if you actually perforate, if you can see a hole in the mucosa, your CO2 starts leaking out in the lumen, number one. So if you can't continue the tunneling because your CO2 leaking out, then you have to close the perforation first and then proceed. But the problem, I'll tell you, if you pull the scope back, go in the lumen and close that perforation, sometimes your clip catches the muscle below it. And then you can't continue the tunnel. That's the problem because the clips are long. So as far as possible, continue your tunneling by the side of the perforation, complete the tunneling and then close the perforation. You can do it. But in the beginning stage, you can be in trouble. So in case you are not confident of doing anything, simply to save any complication from happening, pull the scope back, close the perforation, close the tunnel and stop the procedure. Abandon the procedure. Leave the patient alone. You can always go in at another site and do the poem procedure later on. And there is a saying in surgery called you can always operate for a second time on a live patient. You remember this statement. So keep the patient alive. Very, very important. Irrespective of what institution, whether you're in private practice or whether you're in government service or whatever you're doing, first and foremost is patient safety. Very, very important. Second, of course, blebs. Suppose there is some injury, diathermy injury to the mucosa. If there is a bleb, hematoma, don't do anything. But if you see a white spot, there is a white charring of the mucosa, I think it is safer you apply a clip. Otherwise, you will have a delayed perforation of the mucosa.
And Dr. Amit, sometimes it happens when the beginner has done 10, 15 cases and there's a fibrosis because patient might have pneumatic dilatation before and they are unable to create the dissection at the G junction. So what is the message to them? Should they leave the procedure and refer? Should they do the muscle dissection and then try to go it? What is the message to them?
Ideally, you should in such situations use the hybrid knife with a water jet. Because the water jet comes with so much amount of force that even if there is a fibrosis, some water enters that area. And you can find some plane. And whatever cutting you do in the tunnel or tunneling, stay as close to the muscle as possible. Even if you cut a few muscle fibers, doesn't matter. That way, you will be able to go in and slowly expand the tunnel. If you are not confident of that, just close it and come out and refer to a higher center or somebody who has got more experience. Or go in later on yourself at another site where you are not likely to encounter fibrosis.
Thank you. And Dr. Amit, one of the very important things you told, and I think you always do an endoscopy a day before or 2 days before, because many of the time if the anesthesia team comes new, I encountered doing the poem procedure from last 8 to 9 years, a new anesthesia team came and they, while patient might have an aspiration. So it is important to discuss with the anesthesia team, do an endoscopy at least 24 to 48 hours, suck out entire content. Otherwise, patient might aspirate. If your anesthesia is not tuned to the poem patient, then there is a high possibility patient might aspirate.
Absolutely true. Absolutely true.
And a very important question, Dr. Amit, like you talk about the stir procedure. Then stir, when you reach tumor, should you do the dissection on the mucosal side first or you cut the tumor on the muscle side?
No. First dissect it from the sides. Dissect from the side, dissect from the mucosa, then start going below slowly.
Okay. Any word about the bipolar device? Because we talk about the knife, but any word, what is your experience about the bipolar device? What do you think, how they are going to perform?
Well, the most important advantage of bipolar is it works on a different, totally different energy technology. It is working on radio frequency, RF. So by doing radio frequency and because of bipolar, you don't create collateral damage. Everything is only at the place where you're doing it. So with this new bipolar device, which is being marketed by Creo, what we call as the speedboat, we can start doing these procedures. But the original speedboat was too thick. So for that, we have to use a thicker channel scope. And that becomes a little cumbersome in the tunnel. But now with a thin device which has been launched of Creo, which is the speedboat, I think the POEM procedure will become even simpler. Because in one device, everything you can do, and that too by using radio frequency.
Another question by Dr. Asutosh Ishan.
Yeah.
Is there any role of pneumatic dilatation and Botox in the era of POEM? Any specific subset of the patient where would you like to do a pneumatic dilatation or the Botox injection?
If you ask me personally, pneumatic dilatation very, very rarely. Botox, yes. Botox we still do in those patients who are not fit for anesthesia, who are very old, a lot of comorbidities, but they are very symptomatic. You can definitely do a Botox injection. Even if for 6 months they have got good relief, it's fine. You can give one more injection after 6 months. Of course, the results of another injection are not as good as the first injection, but you can definitely do that. Pneumatic dilatation nowadays we don't do, because according to me personally, and everybody who does POEM, pneumatic dilatation is uncontrolled tearing of the esophageal muscle fibers. You can't see what fibers are tearing. Now, how can you do anything uncontrolled in an area of an organ which is in the mediastinum? And that is exactly the reason why even now, even in the best of hands with pneumatic dilatation, you may have an unexplained perforation. And if that perforation happens, you are in trouble.
Last question, Dr. Amit, from Dr. Mithun Bhaumik. Predictor of failure for POEM. Problem encountered during the redo POEM.
Predictor of failure is sigmoid esophagus. Definitely not going to work. Number 2 is extremely strong submucosal fibrosis. POEM is going to fail. As far as redo is concerned, no problem. The fact that you have to redo a POEM procedure, that means some fibers are left inside. To go on the opposite side and complete it. Many times we do failures of Heller's myotomy, and invariably we find that some fibers are left inside. All these patients, we do a radial EUS, and we find that the fibers are still intact at the lower esophageal sphincter, in spite of a Heller's myotomy done before. Fortunately, all Heller's myotomy is done anteriorly, and we always do POEM posteriorly. So we go in a virgin field, and we can complete the procedure.
Thank you, Dr. Amit. I think Dr. Jhilmil has come to the stage.
No, sir. No. I just wanted to ask with your permission. I had few questions. So
yes, Jhilmil.
Yes, please, Doctor.
Yes, sir. So, sir, I have two questions regarding. First of all, you showed that at the end of the myotomy, you usually like to cut all the attachments which are there of the muscle with the mediastinum. So, sir, in that scenario, many times the large mediastinal vessels are also running, which we have not interfered with. In that scenario, would you like to do prophylactic coagulation of each and every such large vessels?
If the vessel is if the vessel is really attaching one side to the other, then what happens is, because of that, the two edges of your muscle tend to come near each other. Okay. If that is the case, this is the technique which I have evolved slowly over the last so many years. I usually free the entire edges from below, by which the muscles separate very widely and they don't come near each other in the future.
Okay. The second question is, many times that usually type 2 perforation happens near G junction at the time of where the scope creating tunnel is the maximum difficult. In that scenario, after the myotomy, the G junction is still very fragile and the mucosa is very, very soft. So if many times the perforation site extends because of the injury by the clips. So in that scenario, would you do you use some different kind of clips? We usually use either Boston's Resolution 360 or Maydeo clip. Do you have any different kind of clips or different size or the teeth which you can, chances of success of closing that perforation increases?
Number one, I'll tell you what. Number one, the clip has to be opened quite widely. So you should need those type of clips. Number two, the clip should be such that it can approximate tissue very well. There are some clips we don't approximate tissue so well. Number three, the clip should be easily rotatable. Very easily rotatable. Some clips don't rotate the way we want.
Yes.
And number four, when fire the clip, there should not be a sudden jerk. If there's too much of a jerk while firing the clip, it can tear the tissue. If you ask me just now, the clip which fits into this description the best is the Maydeo clip, or we also have some Microtech clips which are not freely available in India. They are also extremely good and they behave like the same way. Olympus clips don't do it with a jerk, but Olympus clips don't rotate so well. That is
Yes.
my personal experience.
Yes. And sir,
Austin resolution clip, there is a lot of jerk when you click it, when you fire it.
yes.
You actually get a sound tuck like that.
Yes. But the Boston clip teeth usually do not injure the mucosa, but I find that Medora clips teeth usually they go very deep into
Yes.
the mucosa.
Yeah. They are little sharp. They are little sharp.
Yes.
Yeah. Even the instinct clip from Cook is very good.
Yes.
Very good for closure.
Yes. And instinct clip is very useful for the upper, like C poem or Z poem, where the butt is really very small and it does not interfere
Exactly.
with subsequent clipping.
Exactly.
And so last question regarding your point pneumatic dilatation. So many times we see that the patient is having a sigmoid esophagus or usually dilated esophagus. The mucosa is completely unhealthy, but patient is very symptomatic. In that scenario, we usually like to clean the mucosa and place the RT for the mucosal healing. But patients are not very, compliant cosmetically because they have to go for job or anything. So in that scenario, would you like to go ahead with a 30 mm pneumatic dilatation just for the mucosa to get healed and patient can take liquids, or you still do not want to?
You can do. I'm not saying that you can't do, but do it very carefully. So you can do a maximum 30 mm. Don't exceed that. Okay, and at least some symptomatic relief the patient will have.
Yes, sir. So hand over to Rajesh Puri, sir. Thank you, sir.
So there's another question from Dr. Rahul Diotel. How deep to cut muscle fiber?
Oh, completely. I told you, I personally prefer full thickness cutting. It makes your procedure much faster and more elegant. There's no reason for saving the longitudinal fibers because after cutting circular, the longitudinal is anyway going to separate.
Then another question by Dr. Pawan. What if we do myotomy till TPV sign?
TPV sign is only at the OG junction. So you have to go at least 2-3 centimeters beyond the OG junction. Only then you will get a proper result, optimal result. Otherwise, your patient will continue to have some dysphagia. So you have to go beyond the TPV sign.
One last question from my side. I know you have discussed very nicely that entering into the tunnel, you have to clean the side margins, you have to do the deep submucosal dissection at the apex. But the beginner who is doing in his own center, and if you don't have a mentor, and you are not able to go it, what should, like first case when I did, I used the balloon. I know that's not right, but I did the balloon dilatation of that site. I put and do. So what is the trick? What are the things they can do to enter into the tunnel?
See, one is this balloon dilation. Second is you rotate the scope. Rotate the scope torque completely and go from the opposite side.
Like anterior.
Like anterior. You turn the whole scope as if you're going anteriorly. So your big wheel, what you're turning is in a different direction. Okay. See, normally when you're doing posterior, to move the big wheel away from you to go in the tunnel. Okay. So you rotate the scope in such a way that the incision comes anteriorly. Then you move the big wheel up towards you. And that way you can enter the tunnel. That is a technique which you can use.
Okay. The last question, Dr. Amit. When you are doing in a small center, you might have a one scope or two scopes. Any instruction to the junior that poem scope, because you require up and down knob, should be very good in the poem procedure. What is the take home? Because the scope which has a floppy up and down knob, sometimes it is difficult to enter into the cavity, even by the best of the people. So any message to them about carrying the scope, or they should keep a separate for the third space? What is your point about this?
There's no question that your instruments have to be perfect when doing a procedure of this nature. Okay, so if there is a play in your wheels, at every step and any procedure you do on that scope, you're going to find trouble. Okay, so you have to make sure that your scope, at least if you are entering into third space procedures, keep proper equipment for that procedure. Don't use any equipment which is not working properly, as what Rajesh said. I think this is a prerequisite. There's no question about that.
So with this, Dr. Amit, thank you. And I think this was an excellent lecture. And how to do poem, how to learn poem, what are the tips and tricks, what precautions you are going to take. Thank you for giving such a illustrative lectures and guide the juniors how to proceed with the third space endoscopy.
Thank you so much. I really wish and hope that many of those who attended this have got motivated to enter into third space endoscopy.
Dr. Jilmil, would you like to say some word?
Yes, sir. Thank you so much for such a lucid, comprehensive, and masterly lecture about starting your journey about in third space endoscopy. I'm sure that all the participants must have learned a lot about the lecture, and thank you for taking your time, because I knew your today you had many commitments, simultaneous commitment, but still you took out the time and gave such a masterly lecture. And I would like to thank you to Dr. Rajesh Puri sir for taking time from his busy clinical practice and having such active and interesting discussion for almost 30 to 35 minutes, which is really nice. And I think all the participants must have learned a lot during the entire session. So with this, thank you everyone. And also I would like to announce that the next paathshala session will be on 27th of October. It will be on abdominal ultrasound by Dr. Pankaj Gupta, what gastroenterologist should know about the abdominal ultrasound tips and tricks of basic abdominal ultrasound. Thank you, everyone. Thank you, sir.
Thank you. Bye.
Rajesh Puri, sir.
Bye.
Thank you,
Bye.
sir. Thank you, sir.
Bye. 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 Bye.
Thank you, sir. Thank you so much.
Recording.